Recording started.
Good afternoon. I'm Michael Hager with the National Quality Center, and welcome to our November 17th End Disparities Learning Exchange webinar entitled Setting Baseline Data for Disparities. The time is now 1:00 p.m. Eastern, and while we have a number of people who are continually registering for our event and joining, I want to make sure that we make good use of today's time and that we get going. On behalf of the National Quality Center, we're excited to announce this webinar as part of our ongoing learning exchange, which kicked off last month. Please note that today's webinar is being recorded for later replay. We always post the recorded version of the webinar on the link where you can access our events on our website. I'll be demonstrating how to access the recording and the slides momentarily. Before we get too far down the line, we'd like to invite you to just enter your name and a little bit about yourself in the chat room, your organization name, city, state, and maybe what interests you about disparities as a way to start. This gives us an opportunity to get to know each other. Even though we have a crowded space of around 225 people expected for today, we can still have a chance to interact with each other through the chat room. And I'm going to get started with that. Michael Hager, NQC, New York, New York, Manager of TA, and Disparities Program Lead. And while we're entering our information, thank you so much, everyone, for sharing. I'm going to move on to the next slide and cover some ground rules. Per usual, we invite you to actively participate in today's webinar by asking your questions in the chat room. We'll have two different opportunities for question and answer for the different segments of today's webinar. We ask that you don't put us on hold. While we have muted you on entry, if you happen to become unmuted, your on-hold music could become a distraction for others who are trying to pay attention to today's webinar. So please do avoid putting us on hold. You can press the orange button to the right of your name during our question and answer session to have your questions asked live in the webinar. Of course, we just ask you to remute your line by pressing that same button after you ask your question to ensure that we don't have any unwanted distractions. Please note that the WebEx system will be emailing you an evaluation for today's webinar shortly after the end of today's program. We kindly ask you to complete that webinar as it really does help us to drive our future content and the programs that we are providing you at National Quality Center through the End Disparities Learning Exchange. And of course, as I already have mentioned, the call is recorded for replay for those who missed today's webinar. Now, I promised you that I would show you how to access the slides and the recordings for today's webinar. So let's go ahead and do that now. If you go to our enddisparities.org website, you'll see our Think Big, Start Small banner and two banners beneath that. You'll always see the Join Us, which is a quick access to the current most upcoming activity. But if you click this review area right beneath it, it navigates you to all of the recordings and slides for the events that have happened to date. You can also see if we have posted slides or other information for upcoming activities. So since today's activity is setting baseline disparity data, 11/17/2016, I'm going to click there. From here, you can see that the webinar slides are located in the set of buttons. If you go ahead and click that, you can see presto, I have downloaded the slides and I can open them at my leisure. After the webinar has completed, this Register for Event button will turn into View Webinar Recording, and you can click that button to access the webinar recording. All right. So, of course, if you have any questions about that process, you can feel free to email me, Michael, at nationalqualitycenter.org at any time, or you can ask questions in the chat room, and any one of our wonderful staff and friends will be able to help answer your questions and concerns. So at this time, I'd like to turn it over for some welcome remarks. We have Clemens Steinbach, the Director of the National Quality Center, and Emily Chu, our Project Officer for the National Quality Center at the HIV/AIDS Bureau. Clemens, would you like to provide some welcome remarks to the crowd today?
Absolutely. Warm welcome to all of you. It's our great pleasure to have so many of you joining us today, and also to receive a wonderful reception about the idea of working jointly on reducing disparities. I think working on disparities is probably one of the key public health priorities that we can focus on for the benefit of patients that we all serve in our local communities. I welcome all of you. I hope you take advantage of the various resources we have available, presented here through our webinar, when you visit our website at end+disparitiesexchange.org. And I just encourage you what Michael said about using the chat room for posting any questions you might have. We have several staff and friends individually dedicated to really try to answer all of your questions. So again, a warm welcome, and I will ask now Emily Chu. She is the Public Health Analyst at the HRSA HIV/AIDS Bureau for her opening remarks. And a warm welcome to you, Emily, and thanks so much for being on the call.
Thanks, Clemens. This is Emily Chu. I just wanted to formally welcome everyone on behalf of the HIV/AIDS Bureau. We're really excited that you've taken the initiative to be a part of this End+Disparities Learning Exchange. Today, we're going to take a deeper dive and really take a closer look at the Disparities Calculator and all the great tools and resources that are paramount to this learning exchange. Also, we're going to be talking about Partners in Care, which I personally think am mostly excited about. I think it's a great opportunity for our stakeholders and consumers to come together and be a part of this effort. Myself and Marlene Matoski from the HIV/AIDS Bureau will be live on the entire webcast answering your questions in the chat box. I'll also put our email addresses in the chat box, and if you have any questions or would like to reach out to us directly, we're happy to triage or help in any way that we can. So, Michael, I'll turn it back to you to get the ball rolling.
Thanks so much, Clemens, and thanks so much, Emily. A couple people have pointed out that the entry beeps are a little bit distracting, and I apologize for that. I am looking for a solution to that right now, and I cannot find one. But perhaps if anyone on my team knows how to do that, you can come and let me know privately. Thank you very much. The End+Disparities Learning Exchange is a 9-month initiative that promotes the application of improvement interventions to reduce HIV-related health disparities in 4 key populations while building, sustaining a community of learners among you, the RYMI HIV program recipient community. We offer a number of informational opportunities, including today's webinar. We have other activities that are especially directed to consumers called Partners in Care. We have a preview of that type of webinar experience coming at 2 p.m. The second half of today's webinar, as Emily had mentioned. In addition, we have informal opportunities for folks to come together to dive deeper into discussion in the presence of the faculty, but of course participants, recipients, and consumers who are living and breathing this work every day, your peers. So we invite you to check out our office hours. They cover a range of topics that are all revolving around a single monthly topic. NQC is funded by the HRSA HIV/AIDS Bureau since 2004 and provides technical assistance to all RYMI HIV/AIDS program recipients to build sustainable clinical quality management programs. Over 90% of all recipients have access to intensive NQC offerings and take advantage of our various services. The Learning Exchange is an extension of these offerings. And you can see that the Learning Exchange is included in our highest level of communities of learning on the right of your screen here. But we also offer a number of different activities, including one-on-one coaching that, depending on your need and requests that are appropriate and within our scope and have approval, we can assign one of our local field experts to work with you directly. And we have a number of other formal and informal ways to get involved with NQC to think critically about your clinical quality management program at your RYMI HIV/AIDS program recipient site. If you'd like to learn more, you can visit us at nationalqualitycenter.org. So our webinar today is broken into 2 sessions, as we've already mentioned. The first 60 minutes, we'll learn more about the end disparities learning exchange and a key tool that is the Health Disparities Calculator. And we'll be doing a demo drive and entering data and discussing that with everyone on the line today and making sure that we answer all of your questions to the extent possible. Afterwards, we're going to have a 60-minute session that is looking at Partners in Care, the consumer involvement mechanism for this learning exchange, and a great way to think about how to involve consumers like me in this important work that we're doing. I'm sure that many of us actually wear the dual role of being a consumer and also being part of the system, I think that it's a treat for those of us who aren't, just to kind of see how we can engage more of the consumer community in the work that's going on in our sites. Each 60-minute session will be followed by a question and answer session, or the question and answer session is built into that 60-minute segment so that we can engage all of you in a dialogue of how this work can impact your work in a positive way at your home sites. Today's learning objectives follow those 2 different categories. One, we want you to understand the principles of disparities analysis using the NQC, or the Health Disparities Calculator. We want you to think about some common next steps that you can take as learning exchange participants to close disparity gaps once you've identified a focus population using a tool like ours or whatever methods you already have available to you at your home site. We'd like for you to be able to explain the process for maintaining and progressing along the QI path for disparities projects as a follow-up to that. And then for our second half of today's program, describe Partners in Care and its toolkit of resources, and then name key methods RYMI HIV/AIDS program recipients can use to bring people living with HIV on board to assist with this work as Partners in Care. So, let's dive a little bit into this Health Disparities Calculator. And I'd like to start with some interaction here. Is there a disparity? Looking at the data here, is there a disparity? If you'd like to participate, you can use the check mark right beneath the participants list. What do you think? Is there a disparity? And you can enter in the chat room as well if you think that you know where the disparity is and how you might approach working on that. And I'll leave a minute for you to look at these numbers and to think about whether or not you can read in the tea leaves here if there is a disparity.
Hey, Michael, this is Emily from HAB. I was just wondering if you could please start to announce the slide number that you're on for those individuals that are just on audio only and not on Adobe, or on the WebEx, I'm sorry. Thank you.
Thank you very much for that reminder. We are currently on slide 10. Yeah, so I see that quite a few people are asking us to slow down, so I will slow down a little bit. And I also see that quite a few people have responded that they see a disparity in the data. So this is often where we're at with this type of process and project, right? We're looking at a data, we're looking at a set of numbers, and we're trying to make sense of it. And it's hard to make sense of it just looking at the numbers. And of course, all of us have our own individual experiences as individuals, whether we're living with HIV or not, in terms of whether or not we have experienced or seen or heard of disparities and outcome disparities for specific groups. And so we need some way to think about this consistently, and some way to make sense, hopefully scientifically, using data to drive these types of discussions and decision-making pathways. So I've moved on to slide 11. So the Supreme Court of the United States has a set of precedents that it calls disparate impact. And generally speaking, as we know, based on what I just said, people have different, allegiances or different ties to different groups, or scientifically or statistically, we have different feelings about various methods, the application of methods. And what this means is that overall, scientists and statisticians disagree on how to calculate disparities because there are so many methods and because we have so many other things that we bring with us when we try to have these types of conversations with people. The most uniform method for calculating and interpreting disparities comes from the Supreme Court of the United States. And disparate impact precedent has been used to look at housing, employment, and jury selection over time. It's not been used or applied to healthcare in the past. But what we're hoping to do here, since healthcare and health disparities is such an important national priority, is to build a bridge and to try to bring some sort of, consistency and scientific approach to the way that we talk about disparities in healthcare. So we're going with the methods that are included within the Supreme Court of the United States disparate impact case law. So this is going to be a lot of information, and it might feel like a whirlwind for quite a few of you. You'll see that the NQC guide, Qualifying Disparities in HIV Care, is a companion document to the calculator that we're going to be reviewing momentarily. And I'll show you how to access that when we go to pull out the calculator and to use it and to do a dry run in front of all of you in a couple of moments. Some of the overviews that are included in this guide are what is a disparity, how do we qualify disparities statistically, and how do we intersect probability and impact for disparity work in quality improvement projects. The mathematical background and calculation walkthroughs are also spelled out like a textbook within this guide. So in case you're looking at the calculator in the summary and analysis pages and you're still left scratching your head and you'd like additional information on the background formulas and how they're constructed, in addition to the methods that go into that, you'll find each of those within this guide. You'll find it for the absolute disparity, rate ratio, comparative disparity, odds ratio, and absolute impact methods, which are applied to every single measurement that we do in the calculator. And this will hopefully help to bring that into focus for you as someone who's using this tool in the community. I'm moving on to slide 13. In addition to the guide and the workbook, there are 5 different PowerPoint presentations that help to break up the topic. We know that there are a number of different styles of learning out there and that something different works for everyone. We know that some people are going to be fine downloading the calculator workbook and plugging and chugging. But we also know that some people are going to want to look through that guide and to really get a better sense academically of what this tool is and how it's to be used. The PowerPoint presentations take it back a step further and again, break it up into 5 different sections that we can use to clearly understand what is a disparity, why are we focusing on 4 subpopulations, what is this calculator tool, what are the assumptions behind this calculator tool, and how do we move forward with selecting a single QI project based on our use of this calculator tool. Our way of thinking about this is that in general, within all of our communities, there are a number of different styles of learning and different needs in terms of these styles of learning. So we highly recommend the co-dissemination of materials just by sharing the link where they live. They're already all included together, so this goes a long way to help you co-disseminate those materials. This, again, is a very challenging task, and there are a lot of feelings that come with this, personally and statistically, scientifically, and by co-disseminating the guide, the instructional slides, and that calculator tool, we're hoping that we have happy users and participants in the End Disparities Learning Exchange across the United States. And of course, as always, I'm available to answer your questions if you contact me at any time, michael@nationalqualitycenter.org. In addition, for those of you who are already engaged with one of our ongoing technical assistance experts through the National Quality Center, our experts are also familiar with this tool and also know how to reach me. So you can contact them and reach out to them at any point in time for assistance in this tool. Moving to slide 14, let's start what is a health disparity? So the Supreme Court of the United States and disparate impact case law helps us to simplify this question. We're looking at disparate impact that examines effect instead of intent. So often we think about this in terms of what someone is setting out to try to do. And this is assuming that people who have disparities set the system up that way, and it's rigged to create these disparities. That's not always the case. In fact, most people are well-meaning people. All of us here today are actually driven by our passions to help as many people living with HIV as possible within our power. So we need to think about this in terms of effect. And even if we're well-intentioned, we have policies, procedures in place, we have practices, we have outreach, it still may turn out that the viral load suppression rates and the retention rates are differential among the populations that we're serving. This doesn't mean that we're bad people at all, but by looking at the effect of our policies and the effect of our work, we're going to be in a much better position to really truly tackle this major problem that is a national priority of disparities in health outcomes. Again, these statistical tests that are included in this tool, guide, and slides are built on decades of precedent used by the Supreme Court of the United States in settling landmark discrimination and disparity cases around employment, housing, jury selection, and more. Moving to slide 15. So, how do we assess effect? Well, one of the most important things, as I've already mentioned, is that we need to ignore our instincts, gut, and passions, which seems really strange because what got each of us to this point, for the most part, is our passion and our gut desire and our instinct to help our brothers and sisters living with HIV to achieve optimal health outcomes. We need to put that all aside and to think scientifically, using statistics to identify where true disparities lie in health outcomes. In other words, we need a basis of evidence. The presentation will help you understand how the math works so that you can trust the results in the calculator tool, in addition to feeling comfortable in using that tool itself. Slide 16. Most of us probably are on the left side of the fence here. Dear math, I am not a therapist, solve your own problems. But through this calculator tool, where everything is automated, as you'll soon see, we're hoping that people will move more toward the center. Dear math, I love you forever. Perhaps that is a pie-in-the-sky wish from me, but hopefully it's something that you'll feel as you do this work within your own home sites and you dig into the calculator tool, those informational slides, and that NQC guide. Moving to slide 17, let's look a little bit at what the tool includes so that we have an understanding of what it is that we're trying to accomplish using this tool in the End Disparities Learning Exchange. On slide 18, we can see the tabs of the workbook, and you'll see them as well when we're looking at the workbook itself. But I just wanted to quickly cover for you that in the workbook itself, there are instructions. There are descriptions of each tab and instructions on how to enter the data. The instructions slide also includes a handy workflow diagram that you can use to start thinking about this in terms of your processes within your individual agency or at your agency that might be a network of sites that are strung together. If you're an A or B, or sometimes a D-funded agency. In addition to instructions, there is a slide that covers statistics basics that is a refresher on some of the terminology that you'll see within the calculator. And this is a helpful reference point, especially for talking to people about this tool who may be less familiar with statistics and might be left scratching their head around some of the issues around confidence intervals, and ability to qualify disparities. Of course, we have a data entry page. It's the only page where you need to think about entering data in the calculator, and you'll see easily how the data flows throughout the tool after data are entered. We have summaries that are a dashboard of final calculation results and analyses that provide the background statistical values and analysis that inform those summary dashboards. And we recommend that you share the analysis page with folks who are more higher level statisticians, medical directors, people who are skeptical of data and want to see behind the scenes. We recommend that you tend to share just a summary with the clinical quality management team at your site and with other groups that are involved in decision making because it simplifies it for them in a single view. And you'll see what I mean in a moment. So let's go ahead and check out the Health Disparities Calculator. Of course, there's an invitation here on this slide as a placeholder to try it on your own. But what I'm going to do now is share my screen again. And let me show you where to find the calculator. So if you're on the end+disparitiesexchange.org website, you can click this button here that says Resources. In addition to a plethora of other resources available, you can click the one that's shaped like a calculator, and it says Health Disparities Calculator. By clicking here, you'll see a description of what the calculator is and a little bit about how it was made. And at this time, I'd like to give a special shout out to our friends at New Solutions, Inc. It is a group that is based in northern New Jersey that helped us to think about this tool in depth. And I don't want to steal their thunder too much in terms of their process when they initially created this tool. But of course, I wanted at this point in time to make sure that I could call them out and the important work that they do on a daily basis on behalf of the Bergen-Passaic TGA in Patterson. I see Ray is saying, go Pat. Indeed, go Pat and go Naomi, and thanks for all you do. We'll hear a little bit from Pat later on in terms of their process in developing this tool. But again, as promised, one of the main reasons I navigated you to this page, and again, for those of you following at home, end+disparitiesexchange.org, click Resources, click Calculator. The reason why I'm showing you this page is that you can see right on top here is that NQC guide that I mentioned. We can see the calculator workbook. And each of those 5 miniature PowerPoint presentations that goes through the segments and chunks it up pretty well into about 20 slide segments. What is the calculator? What is this disparity project? Why are we focusing on 4 populations? What goes into the calculator functionality? And also, how do I use this information for quality improvement? As promised, I want to demonstrate how this works so that we can all feel comfortable in accessing this tool by ourselves. So here it is. The tool opens up into the data entry page. I want to just point out what I had mentioned before, that we do have an instructions area that includes a detailed description of what you can find in the calculator, a disparities calculator data entry walkthrough that describes each area where you'll enter the data. And we're going to be going into this in a minute, so I'm not going to focus on that just right now. And here is our handy-dandy workflow for individual organization disparities calculation and group or network-wide disparities calculation. Here is the Statistics Basic tab. You can see a little bit about the populations, how they're defined, and how disparities are defined. You can see a little bit about the statistical terminology used in the tool, if you need that refresher. A little bit about what we mean when we say yes, maybe, and no disparity in these summaries, and a tip on how to interpret results. You'll notice throughout the workbook as well that there are 2 ways that you can navigate. We have macro buttons, or if you're comfortable with Excel and toggling between tabs, we also have our tabs on the bottom, clearly labeled. So let's test this thing out, right? We have each of the areas where we can enter data are in red boxes, and that instruction is right here. So let's say I am Michael Hager. Oops. Actually, I'll say that I'm reporting from NQC. I am Michael Hager. This is for the period 6/1/2015 through 5/31/2016. And I am making this report on 11/17/2016. Data sources, we'll assume that I got this data from Careware. Now, let's look a little bit at the data that I had entered previously. So 289, 722, 211. By the way, this data that I'm entering now is being drawn from slide 10, which is the initial question I asked you, is there a health disparity? So we're going to demonstrate how this tool can help us answer that question. Clemens, or Emily Chu, while I'm entering data in the calculator here, have there been any conversations or questions in the chat room?
Hi, Michael. This is Clemens. So on my screen, we see your test stub. So I don't see – oh, I see here the chat room. I will go through in 2 seconds because I think you have to – I had to click in an additional button in order to get access to the chat room while we see your entries in the on the spreadsheet. I think the question was where can we get the tool? And just a quick reminder, if you go to our website at end+disparitiesexchange.org and click on the resources, you will find the tools and the other helpful guides that are all there in one location for free download for you. And then the next question was, can the calculator tool be expanded? And I would suggest to you to contact us, and we can talk this through with you. Our exchange focuses on the full subpopulation that you see here on the screen: transgender, MSM of color, African American, Latina women, and youth aged 13 to 24. But I think you just contact us, send us an email, and I will go through that I'll put our email in the chat room for further communication about this. I will put in our chat room, Cabrica, I think there's a question about the tool. I will send you out the link in the chat room in a few seconds, and so you can download it right from there. Michael, can I turn it back to you?
Absolutely. Thank you very much for that, Clemens, and thanks. Keep those questions coming if you have them. And as Clemens mentioned, if you roll your mouse to the top of the screen, a little bar will come down, and you can click the button that says chat to make sure that you can see the chat as people, as I have taken over your screen here with this presentation. One of the key things I want to point out in using this tool, because this is a point of confusion for some people, is that the total is your total clinic population. And these population values are just the population values that we're looking at, just transgender people, just MSM of color, just African American, Latina women, and just youth. They will not add up to the total because, of course, our clinic populations are made up of many other people as well. So I just want to point out that the way this tool is working and the way it is set up is that it's comparing each individual population against the total less that population. When we think about this, and this is for those of you who are statistics buffs, normally we need to have a comparison population. And a comparison population is one of the key sticking points when we think about this, scientifically. And it's one of the areas where statisticians and scientists disagree on how to create appropriate comparison groups when we're doing disparities analysis. We're kind of cheating here in the way we do this, but it is, in a way, the best way to have a consistent comparison group. We're looking at everyone in our group of focus versus everybody else. And in doing that every time, at least we have a consistent basis for comparison. I'd like to remind everyone that clinical quality management activities are not research, and it's not pure science. This is one of the reasons why we're okay with the fact that we're doing a second best method. This may not be the method that you would use to write a research paper. In fact, your research paper might not make its publication if you used a method like this to create comparison groups, but it is perfectly fine and acceptable to use this type of comparison group construction and methodology when doing disparities for clinical quality management and quality improvement purposes. So I have entered my data here. I don't have anything to add or any insight on data limitations, so I'm going to leave these fields blank to the right. Let's go ahead and see what the data says in terms of where we might have disparities. So I'm going to click on the viral suppression summary. And, okay, good, I didn't make an error. We can see in the summary that as far as this data is concerned, I must have entered a value incorrectly, because we should see that there are some disparity results available here for us to consider. You can see, let me look at this one. Okay, this one is better, and I apologize for my dummy data that I have here for us today. What we can see is that we have a number of areas that are listed as yes disparity and a maybe disparity and several undefined results. We might want to look in the analysis sheet for a little bit more insight in terms of what is an undefined result, and we'll do that in a moment. But I wanted to just bring your attention to the fact that the data, in fact, trickled all the way through the sheet and populated these summary sheets for us. We can see that the same values and percentages that we had on the data entry are located here across the top. And in fact, the total is also located here for comparison purposes. When we look at absolute impact, what is the absolute impact? That is the number of lives affected by this particular disparity. And what we're saying is that if we took the transgender population and brought the transgender population performance up to the same level as our overall performance, we would be affecting 250 people. MSM of color. If we took MSM of color performance and brought it up to the same level of performance as our overall clinic population, we would be affecting 265 lives, and so on and so forth. This is really important in terms of our prioritization of projects for selection, and we'll return to that momentarily. One question that I see in the chat room that I want to address immediately, because thank you, Barbara Keene, for pointing that out. It is, in fact, possible for people to be a member of multiple groups. In fact, a gay transgender person who is age 22 would end up in 3 different groups, right? If I am a female to male transgender person who identifies as a gay male and I'm 22 years old, I would in fact appear in those 3 groups. That seems confusing on the surface, but it's really not, because what we're doing is we're looking at each set, each population set in its own right, in its entirety. And the population or the intervention that we would select to work with transgender people should be one that is appropriate and evidence-based for improving performance for transgender people, regardless of other factors. We might drill down our data further to get more information on who these transgender people are and what their other characteristics are, so that we can potentially cater different interventions that will work more or less well with different segments of the populations that we have selected. And then, of course, we'll be further downstream once we've selected a population. But I did want to just point out the fact that it is possible for people to be in multiple groups. Thank you again for that, Barbara. Moving over to the engagement analysis. The analysis page is, again, where you can find a lot more information on what's happening behind the scenes in this calculator. And when we look at the top of the page, we can see, again, a reminder what measure it is that we're looking at. we can see our individual patient population data that we entered here in white, and then the calculation occurs where we subtract that population from the total population is above that in green. So in effect, what we're doing for each of these different calculations is we're comparing rows 4 and 8, we're comparing rows 5 and 9, we're comparing rows 6 and 10, we're comparing rows 7 and 11. Youth versus total excluding youth. MSM of color versus total excluding MSM of color. See what we're doing here? When we look for each of the individual, when we look through each of the individual calculations, we can see more clues. And these clues and cues are taken right from that NQC guide. The sliders even look the same in terms of helping us understand where this data comes from and how it was calculated in this tool. And we can see that if our initial scores are all above 0.5 or 50%, that's when this statistical test works. If they're not all above 50%, that's when we see something that says undefined result. And again, we have this key that's handy-dandy right here within this blue box for absolute disparity. We can see that the comparisons, as promised, transgender people versus total excluding transgender people, MSM of color versus total excluding MSM of color, are individually calculated, and we have the disparity value included here. Disparity values that are above 0.1 are considered disparities. So, sure enough, they are marked yes, disparity. And we have the maybe disparity because the calculated result for youth versus total excluding youth is 0.08, which falls between 0.05 and 0.10. For those of you who are statistics fans, you'll know that when we're calculating relative risk and when we're calculating odds ratios, it's important to have another guide there, and we're using confidence intervals in this case. And confidence intervals are programmed to have very similar conditional formatting and also give us a lot of information in terms of where we're seeing disparities. Now, you'll remember on the summary that we saw undefined result. And we're looking here in our key, and we can see that any initial score that's over 0.8 will actually make the comparison invalid. And since we're looking again at the top with results that include values that are above 0.8, that's why this entire calculation is undefined. For comparative disparity, it's a similar thing. If any initial scores are above 0.8, we can see an undefined result. So we're populated all undefined results here. Now let's look down at the odds ratio, and we can see that the confidence intervals are calculated, the odds ratio values are calculated, and we have a similar key here available for us to look. And last but not least, the absolute impact calculation. Absolute impact is a multiplication of the absolute disparity by the size of the population that is experiencing the disparity. And that's how we determine the number of lives that are impacted by that disparity. And we can see the same color coding that was used on the summary sheet is included here in the analysis page. So, coming back to the engagement summary, we now have a much better understanding of why we have some undefined results in the middle, why we have yes disparity factors for absolute disparity, and why we have yes disparity findings for odds ratio. The last thing that I want to talk about with this tool today, because I want to leave plenty of time for your questions because I know you have many, is that when we're thinking about how to select projects for disparities in health outcomes, we want to find the intersection between impact and probability. The probability, as described right here on the page under interpretation, is based on the number of yes disparity findings we have per the tool. These findings together help us to understand that it's more probable. that there is a disparity. So any of the transgender people, MSM of color, African American, Latina women that have 2 yes disparities is more probable that there's a disparity than youth, where there's a yes and only 1 maybe. When we look at impact, that's a number of lives impacted. So thinking about this, I would, if I was leading the clinical quality management team for this agency, I would say that we have equal probability for there being a disparity among transgender people, MSM of color, and African American and Latina women. But we know that the disparities at play are affecting more MSM of color than anybody else, although transgender people are close on their heels. I would want to engage my clinical quality management team to decide whether we focus on MSM of color, the most impacted group, or transgender people, based on the merits and the other conditions that we know are happening within our home agency. And by creating this intersection between probability and impact, we're going to be setting ourselves off to be most successful in selecting our priority population to work on in this initiative. So I just wanted to take a moment now to see if there are any questions. And before I do that, I actually know that there are a number of people, again, who have been working on disparities analysis for years. And we do have some of the folks who have been using this tool for a long time on the line today. And I'd just like actually at this time to invite those folks to tell us a little bit about their experience in using these tools, creating these tools, and what they found. So I don't know if Pat, if you're on the line still and you'd like to share a little bit about your experience in developing this tool at New Solutions and how it's worked for New Jersey.
Sure. Can you hear me, Michael?
Hello, Pat.
Hi, how are you? And hello to everybody else. I want to thank you, first of all, for taking us through this Disparities Calculator, and also to compliment you on the enhancements to our initial creation of the Disparities Calculator. New Solutions here is very pleased that the calculator is now available for everyone to use in the Ryan White program, and particularly in this learning exchange with the National Quality Center. Just to give you a little history of how the calculator came about, the Bergen Passaic Part A program has a small but very dedicated and very active quality management team consisting of our medical clinics, case managers, and 3 consumers who are now with us on a regular basis. We've been looking at disparities for several years, consisting more or less of an eyeball look at what the H4C reports tell us as we generate bi-monthly reports. Nothing more simple scientific was tried during this time. We were looking at them. We think we saw disparities, but we weren't quite sure. Then Michael and the National Quality Center sent out this very easy-to-understand guidance on measuring statistical significance. And we thought that maybe we could use that to measure disparities more accurately without being experts in qualitative analysis, or quantitative analysis, actually. So we recognized the need to simplify the process, make it easy to use, and not overburden our very busy clinical providers. This was very important to us. Their time is very, how do I say it? It's very limited. So we didn't want to overburden them at all. So New Solutions went about creating this spreadsheet, and that it is now the basis for your disparities calculator. It really does save a lot of time and a lot of effort. In terms of what we were doing with it, our quality management team was introduced to the calculator in 2015, and later it was introduced to the New Jersey Cross-Park Collaborative, which is the statewide organization consisting of 41 clinics that are part of the H4C initiative and meet on a regular basis for quality improvement. Presently, we're using it to measure disparities and to make decisions about populations indicated by the calculator as having statistically significant disparity. New Jersey Cross-Park Collaborative is doing the same thing. And I'd like to make one final point before I leave you. The calculator is a tool. It is not a decision maker. It must be used wisely. It is there to point us in specific directions and then later to help us monitor our improvement initiatives. There are other factors that affect disparity and that are important to us and should be part of the full decision-making process when developing an improvement plan. So I really recommend that you use it, but use it in conjunction with so many of the other important factors that come into play. I don't have anything further to say. I just urge you to continue to use the calculator and to enjoy its beauty. Okay, Mike?
Thanks so much, Pat, and thanks for all that you and Naomi have done. It was brilliant the way that this tool was created, and you have a wonderful team there, and Bergen Passaic TGA is lucky to have you working with them on these projects. I know that there are a couple of other folks on the line who have experience using this tool. Kate, maybe you can share your experience. And you may be muted. See a whole slew of phone numbers, so I don't want to click the wrong one here. Well, we're waiting for Kate Burnett-Bruckner to join us and tell her story. Seema at Crescent Care in New Orleans also has some experience in her role as Chief Information Officer in disparities analysis and the use of tools. Seema, can you tell us a little bit about your experience down in New Orleans? And I can see that Seema is still muted. Here, let me try helping you by unmuting your line.
Okay, I'll speak to myself.
There you are. Hello.
Good afternoon, everyone. Thank you, Michael. So we're a federally qualified health center in New Orleans, and we are looking at top chronic conditions across the agency, our primary care facilities, and identifying patients who are at high need, and initiating an engagement with the care teams where we can work on care plans with them, an interdisciplinary care plan. So that was the initial project that we started. We've looked at conditions like obesity, HIV, cardiovascular disease, diabetes, and risk stratifying our patients. But now what we're working on is enabling dashboards that are available at the fingertips for our providers at their clinics, and which has drilled down functionality and stratification. And what we look forward to doing in the future is use this specific tool and try to incorporate that tool into our existing processes and bring it up for discussion at our college committee meeting. That was it, Michael.
Great. Thank you so much, Seema, for sharing that. And we're excited to hear about how this tool impacts your work at Crescent Care, especially considering all the wonderful, extraction and analysis tools that you have at your fingertips. Kate, have you been able to unmute your line? Okay, I can see the check mark there. She's like, I'm trying.
I have asked Kate, this is Clemens, to send me her phone number. If you dialed in, Kate, that would be helpful. Just send me in a private chat room message. If you send me your phone number, we can unmute you.
Perfect. Thank you. And while we're waiting for that to come, I want to just let everyone know that Kate's team at the Cuyahoga TGA, which is Cleveland in Ohio, has paid an external contractor to create a careware extractor. We are in beta testing for this extractor before we make it available to all of you. But we did want to let you know, if you are a careware user, that soon there should be a custom report available for you to upload into your system that you'll be able to use to extract the data directly from careware, and it'll provide you just the data points you need to enter the total and then the population-wise numerator and denominators for use in this tool. We're really excited for this beta test, and we're hoping that it's going to be successful immediately so that we can share with all of you right away. But we're grateful for our friends at the Cuyahoga County Board of Health for their work on this and helping us out.
So Kate, Michael, if you unmute the following number, that would be appreciated. If you go to the Get section at 216-201-2000.
Kate, can you hear me?
Hello, I can hear you. Can you hear me?
Yes, ma'am. Hello and welcome.
Very good. Sorry about the confusion there. I'm glad you got me through.
Me too.
So really quickly, we are kind of a newly formed group. We've had the pleasure of working with Clemens, actually, and over the past several months, we have decided as a clinical quality group to focus on viral load suppression. So Clemens has actually flown into Cleveland and stepped us through in person this tool, and everyone was so excited about it. So over the next month, we have tasked all of our TGA recipients to use the tool, run their own data through careware, use the tool, and come back to us with some ideas about how they would use this data moving forward. So at the next call here, hopefully I'll be able to give you guys some ideas of the feedback that we got and exact details of what we're going to do moving forward in Cleveland.
Thank you so much. That is very exciting, and I can't wait to hear how that goes in Cleveland. It's neat to see an entire network implementing this in addition to our friends in New Jersey who initially helped to develop the tool itself. So they definitely were, as a state, kind of in the driver's seat as it was coming together. But to see a group like yours that's trying this tool new and how it can affect your clinical quality management program and associated disparities quality improvement projects is very exciting.
Absolutely. Absolutely. We're excited.
Great. Michael, there's a question from Richard on the line, and the question is, should, as a Ryan-Wright-funded recipient, and those who use careware, should they wait till the extraction tool is available?
I think that it's important for you to pull the tool down and to start just messing around with it a little bit to make sure that you're comfortable with it. Because if you have any questions, comments, or concerns, you can certainly clear those with us and your wonderful coach, Nanette Brayman-Yani, in advance, Richard. And for all of the rest of you who are engaged with an ongoing NQC TA consultant, you can engage them in those discussions as well. I think that it's really important to make sure that you're just comfortable with it before we have the data. I know that there are a number of groups who are very well-versed in careware across the country who may have already created their own custom reports. If that's the case, go right ahead and run that data and plug and chug and see what happens. And again, we're available to answer questions and support you in that process too. So thanks for that great question, Richard, and I hope that I answered it for you.
Hey, Michael, this is Marlene. How are you today?
Good. How are you, Marlene?
I'm doing well. I wanted to let you know, in the chat room, we've had a couple of folks who've written in basically around the same question, and it really comes down to, and I'm paraphrasing, we know that the calculator is set for very specific populations, but they wanted to ask about, is there a way to change those populations?
That is an excellent question, and thank you so very much. As you'll learn as you work your way through those presentations, or if you participated in our kickoff webinar, the 4 populations we're working on are actually part of the National HIV/AIDS Strategy and derived specifically from Goal 3A. We figured that we would start with the National HIV/AIDS Strategy because so many Ryan-White HIV/AIDS program recipients have voiced the interest in having some action-oriented way to engage around that strategy and to really make an effort in alignment with its goals. That being said, we know that our country is very big and that each of you are going to have different patient populations and different patient characteristics and patient concerns and myriad other things that are variable and beyond those 4 populations. That being said, we do have a special version of the tool that we call the unlocked version, and that tool is accessible if you contact me directly, Michael at nationalqualitycenter.org, and we can talk a little bit about how to unlock that tool and how to use it. I just want to make sure that everyone's comfortable with that. In the Ryan-White HIV/AIDS program, we focus on the, this is the other part of that, we focus on the right side of the care continuum. We focus mostly on retention, prescription of antiretrovirals, and viral suppression. We know that there are a number of different areas that are starting to think about the integrated care plan and the introduction of more of the left side of the care continuum as well. And so in addition to unlocking populations, we can unlock measures too, so that you can have your own heading there for a measure that's of interest to you, say linkage to care, if that's something that is more of a focus currently in your clinical quality management plan or other activities. So I just want to make that known to everyone on the call today, and thank you, Marlene, for raising that question.
No problem, Michael. There's another one in the chat room I wanted to bring up that I felt like would be easier to just address verbally than typing a whole lot of words. It came from Nora, and she said, could you clarify if a program has, for example, an overall viral suppression rate of 80% or greater, this would make the disparity calculator results inconclusive?
That's an excellent question. One of the reasons why we're using so many different probabilistic models in this calculator is that we want to make sure that whether a program has high levels of performance or more challenged levels of performance, that there's something that the calculator can do for them. So you're right that if we do have overall performance above 80% for either of these measures, the middle two, relative risk and also comparative disparity, are knocked out and rendered undefinable based on these calculations and methods. That being said, just as we saw in the example that we went through, you'll still be able to identify odds ratio and absolute disparity. So we have the 4 methods. It seems like a lot, but it's done that way on purpose to make sure that we're allowing for folks that have higher levels and lower levels of performance to be able to use the tool effectively.
Thanks, Michael. I'm just perusing through, and as you can tell, the chat room is a very small print. But I do see someone, it looks like John is already going to start working on this, and he's going to start making some modified versions of the Core 1 and the Core 3 measures to target these populations, but he's going to look at the CARE reports when they come out. We have somebody who's saying that they're looking forward to getting the unlocked version. I think a lot of folks are interested in this CARE piece, so, you know, hold tight, and it sounds like that's going to be forthcoming. But I think those sort of cover the points. I just want to reiterate, we had a couple of questions asking specifically about the definitions for the performance measures, and Clemens reiterated that we're using the HIV/AIDS Bureau or the HAB performance measure definitions. But I think that covers it. Clemens, did you see any others that came through that we didn't address?
No, I think that we addressed those, and I think, or we attempted at least, and I think that's, I think the one point that's just to make, and I'm just very mindful of the 2 o'clock time, is that I think we should not wait till something else comes out. So if you do have data that you have broken down by the groups we are talking about, you should really start using the tool and don't wait till something else comes out. Obviously, with the facilitation of this tool, it will help you. But, we will encourage you to download the tool and the data that you have. At the end of the day, it's a decision tool, so we hope that you can benefit from it.
Thank you so much, everyone, for all of your excellent questions. I've done a lot of these webinars over time, and I don't think that I've ever seen such an awesomely active chat room before. I don't know, Clemens, Marlene, Emily, if you have any reactions to today's participation and questions, but I'm really excited so far, and I am feeling very energized about this project and the Health Disparities Calculator product and how it can help people in the community here.
Definitely. This is Emily from HAB. I think that's one of the reasons why we are so excited to partner with our friends from New Jersey who created the tool and just really be able to expand on that and offer it to the greater Ryan White community. So I'm excited that everybody is able to access the tool and are just as excited as we are. So this is great.
And Clemens, what's the motto of NQC? Is it something about sharing and shameless?
That is a nice segue to say, still shamelessly, share senselessly. So I think in that motto, take advantage of the tool and make it yours, and we hope that we can be of service to you.
And I'm sorry for making everyone seasick, but somehow my slides closed, but that's why I was able to open them back up again. So without any further ado, the time is 2:07, and I want to move on to our second half of the webinar. Now we're going to focus on one of the tools, other tools that we have available through the end+disparities Learning Exchange, Partners in Care. I have moved on to slide 22. Where I have my colleague Dan Tietz, the NQC Manager of Consumer Affairs, who's going to be helping me out here in terms of providing an overview of Partners in Care. Let me provide for you a little bit of background. Many of you are going to be familiar with the in+care campaign, which is an initiative that NQC and HAB launched together in 2011 and actively ran through 2013. Many of you know that the incarecampaign.org website is still active and is a repository of numerous resources around retention and HIV care, in addition to there being a online database where you can enter your benchmark data, enter and benchmark your retention and viral suppression performance data. The in+care campaign did include a consumer involvement mechanism as well called Partners in Care, and over time, we had a lot of interest from people living with HIV wanting to get involved with this initiative. And so Partners in Care, we carried over from in+care into end+disparities because as a person living with HIV for 14 years myself, in addition to being an HIV quality management professional, I just really believe in the power of consumer involvement and, the power for consumers to join providers and to really make this work extra impactful. So I wanted to provide for you that important background that Partners in Care was not developed overnight by any means or in a vacuum, that this was a community-driven process of people living with HIV developing ways of thinking and interacting with other people living with HIV and ways that altogether people living with HIV can interact with the Ryan White HIV/AIDS program recipient community providers to really make sure that we can be as impactful as possible in this very important work. We took the opportunity to engage people from all over the country in Partners in Care in creating these various roles that we're going to be talking about in a minute, and the toolkits that are part of each role. And we'll also talk about that in a minute. The level of interest and excitement in getting involved in this way around clinical quality management on the part of consumers was something that we did not want to squander. And it took a very long time for us to develop these tools and the toolkits, but it was worth it. Worth every second and worth every call, and I could not be prouder and happier, of the outcome. And I want to take a moment to acknowledge a couple of people within the NQC team. We have Dan Tietz, who's on the call with me today, and two of our peer consultants, Adam Thompson and Dolores Dockery, and a former peer consultant, Bob Tracy, who are all instrumental in creating this tool. In addition, our team leaders who helped us to create these different roles and the tools within them, Dennis Creedon from Oklahoma, Katya Royperd from North Carolina, and Jonas Nicotra from Seattle, Washington. Thank you all. If you're just joining us now, which I didn't hear any login beeps, just to kind of cover, these tools that were developed previously are being adapted for use in the End Disparities Learning Exchange, which is a 9-month initiative to promote the application of improvement interventions that reduce HIV-related disparities in key subpopulations while building and sustaining a community of learners among Ryan White program recipients. We offer a number of different webinars, like today's webinar, in addition to office hours and special opportunities that bring people living with HIV together to talk about their special role in helping to end disparities in HIV care and how we can all work together as a team, providers and consumers alike. Moving to slide 26. At this time, I'd like to introduce my colleague and friend, Dan Tietz, the Manager of Consumer Affairs here within the AIDS Institute and the National Quality Center, to walk us through a little bit in more detail what is a partner in care and what are these roles and how can we make them work for us. Dan?
You probably have to unmute this line, Michael.
Okay. There you go, Dan.
Okay. Hi. Good afternoon, everyone. Can you hear me?
Good afternoon. Hi, sir.
Yeah. So thanks for all of you for participating. It's my pleasure to be on the webinar and talk about Partners in Care. This was an initiative where we really wanted to engage persons living with HIV/AIDS as part of the in+care campaign. In so doing, we created a platform for people living with HIV/AIDS called Partners to really be engaged in the campaign. There are several activities that consumers or roles that consumers can play in Partners and addressing disparities, and we will talk about them on the next slide. So the framework that we came up with was a planning committee, again, made of persons living with HIV/AIDS and providers. They actually met over the course of a year to develop this framework. They take on 3 specific roles, and we'll define them, specifically what the traits and characteristics are of each role. There are specific activities that will help enhance and improve the community's involvement in clinical quality management, and each activity actually has a toolkit to support the activity in the role. Next slide, please. So the roles of Partners in Care, again, 3 different roles, and really define the ways that consumers or people living with HIV/AIDS could be involved in supporting clinical quality improvement efforts. These roles are aligned with personal skills, traits, level of involvement, goals of involvement, and quality improvement needs. So for an example, next slide. So the roles are mentors, ambassadors, and architects. Mentor's role is defined as really supporting individuals, supporting themselves, and helping improve health through self-management and supporting people through regular medical visits. I see mentors as, really kind of like a buddy, someone that is available to lean on for support. Going back to the early days of the epidemic when we actually had buddies that were taking care of people when no one else would. But it's really an opportunity to coach someone and help them with their own self-management goals, whatever they may be. Ambassadors, their role is really about being an ambassador by sharing personal stories of success, what they do in terms of being involved in the clinical aspect of the program, aspect of HIV care, but specifically focusing on talking about how retention and viral load suppression are so important for people living with HIV/AIDS. And then the architect is someone who actually designs, builds, and then implements quality improvement projects focusing on, again, improving retention and viral load suppression. So are there any questions before I move forward? I'm looking at the chat box. It looks like everyone's pretty clear about the roles that we just outlined.
I think people are looking for a little bit more meat. Maybe we'll have some questions when we get into the roles themselves, and we can start a dialogue on how these roles can potentially help people to get more involved in the work itself.
Sounds good. So again, here's listing the roles and the examples. So someone who's a mentor is really helping to support either one-on-one relationships to help support retention and self-management. It could also, be someone who's supporting not only someone who's HIV positive, but a friend, helping them navigate the system, helping them navigate their adherence, maybe taking them or being available during their next medical visit. And then the ambassador is the person who's really sharing, their experience, the patient experience, their own personal experience, and within the organization where they receive health care, and also, talking about why, again, retention is so important, and helping others to really stay in care, be retained in care, and hopefully achieve viral load suppression if they haven't done so already. And then the architect is really, I see the architect as someone who maybe be serving on an internal quality management team or committee. They're the ones that are really engaged in quality improvement activities or efforts. They're willing to learn. They want to be involved in really the designing and implementation of quality improvement projects, quality improvement activities. I think about someone like Dawn Trotter, who's on the call right now. She's an architect. She has been someone who actually was key in implementing a quality improvement project called Panties for Pap Smear. And it was actually adopted from another Ryan White recipient, but it was a role that she took on to really help individuals, women specifically, get their annual PAPs, and by doing so, it was a little bit of an incentive giving people, women, a free pair of underwear. So it's kind of funny and maybe a little risque, so to speak, but it worked, and we saw uptake and improvements in women getting Pap smears.
I'm on a web conference and I don't think my
So there's also some specific traits of individuals in their specific roles. So a mentor, they have strong interpersonal skills. They're comfortable speaking one-on-one to someone. They understand and are good self-managers. They know what the tools are and techniques to stay on top of self-management. They attend regular medical visits. They They adhere to their medication. They're also able to provide techniques and tools to others on self-management. They share their personal stories and their experiences as a patient to really help facilitate retention and care and helping people achieve self-management. You know, self-management is not only about taking on the role of being involved in my own care, but it's believing that I have the skills to do so, or the self-efficacy behind that. So I'm speaking on slide 31 right now. I've been asked to let folks know what slide I'm on. And then the last piece around the personality traits is the ability to express what it's like, the benefits, the advantages of being part of a learning exchange as a consumer and as a partner in care. Next slide, 32, please. So the mentor task, well, we want them to be the voice. We want them to share their experiences. We want them to offer peer support, specifically around adherence, what types of social support are needed. Want to make sure that mentors are comfortable and have the skills to disclose, and also help others do so. Help others get to the point where they're comfortable disclosing their HIV status. And then really building individual self-management skills. Slide 33. So the ambassador, disclosure is not an issue for this individual. You know, maybe they've been involved in their local community as a leader, and they're well identified as a person living with HIV/AIDS. So they're really out about their status and comfortable with that. Also, they're comfortable doing public speaking. They have an opportunity to share their story, and you know, maybe that story is very compelling when they're sitting at a table with others and trying to not only represent the PWA community, but represent, you know, the interest of a group that they're involved in. They're also willing and familiar with Disparities learning exchange goals and local programs that they're involved in. So, I mean, I think an ambassador says it right here as a role model for other people living with HIV/AIDS. Again, a recognized leader within their community, and not just recognized leader, but someone, you know, that's respected that others can turn to. You know, I think about regional groups that the National Quality Center puts together, or quality management team or committee. You know, these individuals are either an ambassador for a Ryan White recipient, a regional group, or other type of network that they're involved in. Slide 34. So the ambassador's task, they're really the individual that's providing the voice and identifying the narrative for other consumers. They're you know, really trying to set the tone of why it's important to be involved in this role. They provide written testimonials about retention and self-management programs. So, you know, they could be a spokesmodel for those retention and self-management programs. You know, they've witnessed that those programs are actually put together very well and have outcomes that benefit people living with HIV/AIDS. So, you know, they're really the champions, I guess, for retention and self-management programs. And then they also can provide presentations to communities about personal experiences with retention and self-management. You know, Michael, if there's anything you wanted to add here?
No, I think that one of the most important things here is just thinking about, you know, the way that these three roles, and I think that's one of the reasons why folks are quiet, is they're thinking about these three roles as archetypes for sets of personality traits and preferences that we have as individuals, and the way that we can get involved in this work and this discussion. You know, I myself would probably, well, I've been an architect for most of my professional life, but, you know, thinking about being an ambassador too, you know, thinking about the importance of, you know, my own healthcare, and how staying in healthcare, you know, engaged with my healthcare provider has led to viral suppression and what's that meant for me, and, you know, why viral suppression is such an important thing to achieve. You know, and I've always been pleased as punch with all of my medical providers, and I'd be happy not only to share my personal story, you know, outwardly, but about the great work that, you know, we do, or they do, because I don't work at Whitman Walker Health in DC anymore, but the amazing work that happens at the Fenway, the amazing work that happens anywhere where I've received my care, frankly. I'm just so excited to get out there and to share the good news with other people living with HIV and other stakeholders, policymakers, other groups, you know, hey, look over here at this great stuff that's happening. How can we make more of it happen, more or less? You know, and hopefully maybe even encouraging and inspiring other people living with HIV to share their stories too. You know, I'm thinking about the I'm Still Josh. I'm thinking about some of the folks on The Body, some of the folks on pause.com. I'm thinking about Tyler Curry. I'm thinking about David Duran. You know, these names may or may not be familiar to you, but, you know, within the HIV community, the consumer community, a lot of these names are familiar. And there's a lot more names, too, that I don't know, because I have my own set of focuses and interests and preferences regarding my own health care and my interaction with the healthcare establishment as wearing these dual hats, right, like being part of the industry but also being a consumer of services. You know, I just want, you know, I want everyone to be thinking broadly about this in terms of, you know, how these roles can really work for people and who they are and what they're about.
Mm-hmm. Michael, this is Clement speaking, and I know Dan has to probably go very soon, but there are two questions from Christine, and we are very thankful for her question. The first one is many of our patients have concerns about disclosing their status, so we have minimal attendance. Do you have any suggestions about that? And that's one question. And the second question is there some type of application process to select people interested in participating in one of these roles that we just talked about?
That's an awesome question, Christine. Thanks so much. My way of thinking about this is twofold. You know, as a provider, you know, you can have a conversation with someone who, you know, you think is ready. They're looking for something more to give back. Or, you know, you have a sense from them that they're looking for some way to give back. I think that making the provider community aware that these roles are out there, generally speaking, you know, and that if you have folks who are looking for that next step to get involved at something that's a la carte and at their own convenience, this is really a great suggestion to get them further involved. The other way that we're engaging people in this is through our consumer community networks that we have. The National Quality Center has a network in its own consumer advisory committee. It also has a network in its training of consumers and quality alumni, and there are other networks too that we have. In addition, those networks are made up of people who are part of other networks, who are made up of people who are part of other networks, and we end up with this, you know, word of mouth kind of like, you know, outward, you know, dissemination of materials through networks. As far as thinking about ways that we can do this more formally, I don't know if formality is the way to go with this, since it's so grassroots in effort, and we're really trying to meet people where they are and who they are, right? So we don't have any type of application or identification process now. It's more up to providers to, you know, see the light in people and to give them or like let them know about this opportunity. And it's also up for consumers to self-select and say, hey, I heard about this and I'm in on it. And so you might find that there are more people living with HIV asking your provider staff about this, hopefully fingers crossed, or saying, I, want to get going as an ambassador. Is there any information you can share with me to help with that? We're hoping that there will be more conversations that come at it from both angles. It's not the responsibility of providers to be doing this work for the consumer community. We have to do a good job for ourselves, too, in self-identifying and finding our own value and worth and stake in this work.
Yeah, I agree. And the only other thing that I may say, I know there was a question around an issue of patients having concerns about disclosing their status. There are programs out there, and I'm happy to share them around disclosure skills building. I know there's videos out there also. But I also think tapping into the network that Michael just talked about, for peer support may be another way to address the issue of disclosure. So happy to share resources with you if that's helpful.
Mm-hmm.
Michael, I really apologize. I'm double booked and I need to run. So I thank you for the opportunity and happy to be available as a resource as things move forward. And again, just thanks everyone for participating today.
Thanks as always for being a friend and an ally, Dan. We really appreciate it.
All right. Take care, everyone.
You too. Hey, before I move on, I see a question from Amanda in the chat room that came directly to hosts and presenters. And she's wondering what type of background screening would we do, just so you do with staff who have client contact to ensure the coverage of essential safety. So what type of safety training is there for people to make sure that, they're secure in this? And that's an excellent question. And it's thinking too much about the way that we do, formal work. We're not going to be telling consumers to go find people, in areas where it's unsafe. Like we wouldn't be telling people to go from, one community into another community and to try to penetrate that. And I think that Dan had mentioned, especially for mentorship, the idea of being a peer and being like truly part of the community. If I think about the mentor role, I'm thinking about this as a white gay man living in a Hell's Kitchen. I know other positive men in Hell's Kitchen, and it's less important some of those other demographic issues and identities that I mentioned, like my whiteness, being male. But if I wanted to interact with other folks, as I do in my volunteer work, when I leave this place, I think about where I'm going to be most effective. And so I think that that is built into these toolkits to a certain extent in terms of finding your voice, and being realistic about what you can do. The whole purpose here behind this toolkit and these roles is to be an advocate. We are not agitating and we are not activists. What we're trying to do is advocate for our brothers and sisters to consider their health care and to put their health care as an important priority in their lives as a mentor, or to just announce to people as an ambassador that there's this great work happening in the field and please come to us to learn more. So these are done, at conferences. These are done at town hall meetings. These are done sometimes in our houses of worship or other community gathering places, and it's done a lot online. I saw some other names coming in addition to the folks that I mentioned, I'm still Josh Robbins, mentioning that that Mr. Friendly is another, idea, that these ideas that we can have face-to-face and virtual opportunities to share this word as an ambassador. And of course, architect is an easy one because, we always have our clinical quality management meetings and board meetings on site for the most part, don't we? So, I really appreciate that question, Amanda, thinking about the safety of the people who are passionate about this and want to get involved, and just helping to make sure that people are realistic in understanding like where they're going to be most impactful, in terms of, self-identified peers and, working within an area that is, that makes sense. I hope that answers that question. So before I answer additional questions, I just want to get through, a little bit more about these roles. I've switched to slide 35. I'm going to talk a little bit about architect personality traits. Architects, again, are people who are part of our teams in clinical quality management committees or as part of our board of directors, working on clinical quality management issues, as so many of our boards of directors do have focused committees on clinical quality management. Architects have interests and skills in helping to design, implement, and evaluate quality improvement projects. It's someone who, as a result, loves data, loves process, and really likes to roll up the sleeves and to think about things in that very process-oriented way, as we do in clinical quality management. They're able to attend and participate in regular team meetings, regardless of the time of day, as they're set by our own calendars within our home agencies. Architects have the ability to learn independently about quality improvement and HIV treatment and care, in addition to the willingness to be able to read, research, and resources that are provided by our staff partners in clinical quality management committees and other venues. Architects value the importance of consumer input into quality improvement activities, and again, are thinking about this from an advocate standpoint. They're not thinking about the me, 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 me. They're not the people sitting on the committee who only and always raise issues that people that look exactly like that person face, but they're thinking broadly about all people that we're trying to serve through our clinical quality management or HIV care programs. Moving to slide 36, architects ensure broad community input in the RIMI HIV/AIDS program provider services. Architects engage consumer advisory boards in quality, especially for those CABs that haven't moved to that point where they're meaningfully involved in quality. This might be another opportunity to get architects involved. I know, again, thinking about myself in that dual role as consumer and also a quality management person, at an agency like Whitman Walker, thinking about how my background is able to inform services or issues surrounding services provided in that clinical setting is really important and valuable. Architects can join a clinical or organizational quality management team, whether it's within just the HIV program or across the whole organization. And architects can continue building personal capacity for quality and, in fact, are willing and ready to do so. So slide 37 introduces the toolkit, and I want to just take a second to see if there are any other questions in the chat room. Can my friends help me identify if I've missed any?
So this is Clemens. Hi, Michael.
Hi.
Thanks so much for the presentation. So there's one question that came up from Karina. It's really about the question, how can I become, in this case, an ambassador? And I think we heard about what the function is. Do you want to just tell Karina a little bit the answer, how you can become one, and that what I think is the heart of the question?
Yeah, I think for now, we're still, as I mentioned before, it took us a long time to put these tools together, and there was a lot of community input that went into it. And our federal partners have graciously offered to help us review and refine these tools to make sure that they're really meaningful and good and useful for people in the field. As a result, there are so many resources that are involved in these toolkits that our federal partners have been working with us and going back and forth and revising those tools and just making sure that they're polished for you. As such, they're not available on the website yet. And so the sign-up, I didn't want to be kind of like a sign-up and then what process. But for someone like you, Karina, who's very interested in learning more, please send me an email and let me know that you'd like to be included in our list so that when we hit that big green button that says go for these toolkits and post them on our website, that you're one of the first people who's able to take a look at them and to have a conversation with us about what it means. I'm sorry that I can't offer a better solution, but it's where we're at. And again, it is such a helpful, important process that we're going through with our federal partners to make sure that the resources we provide to you are good resources.
Michael, I think one thing that you want to talk a little bit about our upcoming Partner in Care webinars as a platform to stay connected. And I think that maybe one step that Karina can do to join us and learn more about it, and then maybe as a next step for her. So that would be, if you can talk a little bit about that, I think would be great for her and for others as well.
I think so too, but I will say that you are stealing my thunder, sir, and I will get to that in a couple of slides if that's okay. Okay, wonderful. Thank you, and thank you for your patience. All right, I'll move to slide 38 to talk about the toolkit. And again, the toolkit is the briefcase for each of these different roles and their activities, and the tools are selected to help support each of the activities for each role. When we think about each of these roles having their own toolkits, we have to keep in mind, too, that these are very function-specific, and there's some general overall information that every partner needs to know. So we have created a general toolkit in addition to the role-specific toolkits, because, again, there's some information that just you need to know if you're going to be meaningfully involved in this work. The general toolkit involves presentation templates on the topic of retention of viral suppression, and there are customizable options for your making a local presentation or an agency-based presentation. There are basics of HIV care, basics of retention, and viral suppression information available for you to learn a little bit more about this stuff in the nitty-gritty, so you feel very comfortable working on this in the field. And then we have information on the HIV continuum of care, resources, journal articles, and presentation slides, and also the basics of quality improvement information. So like before, I want to just do everyone a solid here and to show you where to find this information in general. Going to the end+disparities.org website, you can click in the right upper portion of your screen where it says Partners in Care. That navigates you to our Partners in Care homepage, where at the moment there's placeholder information about what Partners in Care is and a little bit on those roles that we just spent some time going over with you today. In this white space down here is where you're going to find access points to the general toolkit, in addition to some general information on the Partners in Care toolkit and a presentation that you can share with consumers about this that looks very much like the one that we just provided today, and some other resources. Scrolling down a little bit further, you can see information on mentor, ambassador, and architect. And once the toolkits, are finalized between NQC and our federal partners at HAB, you'll see links to those toolkits here that include a laundry list and descriptive information about what's included in each of the different resources included in those toolkits. So for now, you can point people to the Partners in Care homepage. That's part of the End+Disparities Learning Exchange page. And be on the lookout for an announcement from the National Quality Center through these webinars and also through our various newsletters and social media to bring attention and great fanfare to the point in time when these toolkits are available. A question just popped across my screen asking about the timeline for this. We are expecting that it will be ready relatively soon, but I don't want to give the wrong information or the wrong impression. information or the wrong impression about that, because again, we're going through this very carefully with a fine-tooth comb with our federal partners, and want to make sure that we're providing the best possible tools for you. So again, I don't want to lead you astray. It should be ready, by the end of the calendar year, but just in case, I don't want to provide a specific date.
Okay. And I think it's also fair to say, Michael, that if folks are really interested, they should put in their email address in the chat room and in our future announcement as part of our newsletters that go out as part of our End+Disparities exchange, that we can communicate to all when those become available. So if you're interested in, just put in your email address. We're going to be sure that you get added to our mailing list, and then we'll be happy to send it out to you. And just look for our monthly newsletters, and we'll certainly make the announcements right there.
Wonderful. And we have several people who are already taking you up on that offer, Clemens. Thank you very much for sending me those email addresses. Keep them coming. In the meantime, I want to get back to, our presentation here for the day. So let's just recap for you. You might be a partner in care if you can see yourself being a mentor for other individuals living with HIV, an ambassador for all of our good work that we do together within the RYMI HIV/AIDS program community, regardless of our role, position, or part funding, or an architect for designing better care for all members of our community living with HIV. Looking at slide 41, this is the teaser that Clemens had mentioned. Partners in Care Roundtables discussion. This was the first one today. It was appended to the setting baselines for disparity data because we wanted to make sure that we captured as many people's attention, including people who aren't living with HIV, to think about this and to consider this as a strong possibility for including your patient population, friends, family, and others living with HIV in this important work that's a national priority. Each month of this learning exchange, as we've already mentioned, focuses on a different area. And what the Partners in Care Roundtable discussion does is it focuses that discussion of the month on matters that are relevant and important to people living with HIV. And in particular, thinks about these three roles that are the Partners in Care functions and how these three roles can be leveraged to work on a specific issue. December 8th, in 3 weeks from today, is going to be working in teams to end disparities. Myself, Dolores Stockery, and one of our campaign learning exchange consumer spokespeople, Amir Simon, are going to be presenting on that. January 26th, transgender health. February 23rd, MSM of color. March 23rd, African American Latina women health. April 27th, youth health. May 25th, sustaining our gains. And June 22nd, greater than the sum of its parts, thinking about everything that we've done over the course of the 9 months and how we can get that word out there further into the community as far as possible. The version of these slides that you can download online actually have clickable links here. So the red text you see on this slide is a link that takes you directly to that event, so you can copy and paste into your calendars all the information, including the webinar link, the dial-in information, and other need-to-know information about each presentation. So we invite you to go take a look and to, of course, always contact us if you have any questions, comments, concerns about any of these webinars. And we really sincerely hope that you'll join us to think about how we can get consumers involved in this work in a meaningful way. Moving on to slide 42, we have office hours opportunities, as I've mentioned a couple times during our 2-hour program today. Office hours discussions are informal opportunities to dive deeper into the issues. We're talking participant-led and directed based on your questions and the challenges you're facing in your communities in doing this work and in trying to work to make an impact on disparities. They occur on various Fridays from 1 to 2 p.m. Eastern, and we ask that you check our calendar on our website for exact dates and topics. These office hour topics do follow that same monthly editorial calendar in terms of our focus, but it's exploring different specific areas within each of those broader topics of focus. Slide 43, Q&A session. And we have about 10 minutes left for questions. I'm wondering if any of my friends on the faculty have noticed any that I may have missed.
No, I think we caught up to where we were. I think that the emails were really helpful, and I think that if you haven't, just a quick reminder for those who want to be put into our mailing list and then to be added, please feel free to send us your email address, and we will ensure that you are added to our mailing list. And once we have all the packages ready, in addition to what's currently on the website, we will let all of you know.
Wonderful. It's our pleasure, of course, to provide you all these resources. We're really passionate about this work and about clinical quality management and, of course, about ending disparities in HIV care. We know that we're not going to actually end disparities in HIV care, but, one of our mantras is around making sure that, we can do what we can do and we can do it. And what better way than to aim for the stars, because then at least you'll land on the moon. If anyone has any questions, please, you can feel free to unmute your line and ask them live at this point in time in the webinar. Just press that orange button to the right of your name. If you have dialed in and aren't able to unmute your own phone, you can, in the chat room, say unmute me and type your phone number that you dialed in on, and we will go ahead and do that for you. And for those of you who are writing to me asking for unlocked versions of the tool that we went over earlier today, yes, I will totally do that. I can't promise I will get to it today because there are quite a few people who asked for that, and I want to make sure that I don't miss a soul. And for those of you who are being asked to be added to the email list for Partners in Care, I will certainly do that, and you will receive a confirmation email that you are indeed included on that list. Would anyone like to ask their questions live? You can, again, unmute yourself by pressing the orange button to the right of your name, or you can enter your phone number in the chat room and say, unmute me. To our panelists, are there any other thoughts that you have about today's presentation or applicability to the Ryan-White HIV/AIDS program and our efforts today? So thank you for joining all of us in the fierce urgency of now, a famous quote by Martin Luther King. And at this time, I'd like to invite Emily Chu, our federal partner at the HIV/AIDS Bureau, if she has any closing remarks for us today.
Thanks for the opportunity, Michael, and thanks for everybody who lasted for the 2 hours. I know that 2-hour webinars are sometimes really hard to get through, but I hope that you found the content to be as invigorating as we did at HAB and NQC. Thank you, NQC, our partner in developing and presenting this information. We're really super excited about Partners in Care as well as the End Disparities Calculator and Toolkit. The National Quality Center has put a lot of great work into this product, and so we're really excited to support them in getting this out to our recipients of the Ryan-White HIV/AIDS program. So thank you for making the time to be here today. Clemens, any closing remarks from your end?
I just want to echo what you just said, to thank all of you for being on the call today. And this was really a wonderful, engaging webinar, and many of the comments I saw in the chat room echoed the notion of interactivity through the chat room. So I want to thank all of those who put their comments in and their questions, and I want to thank Michael and Emily Chen from our end as well, who really were instrumental of putting this together. And I also wanted to thank Emily Chu and Morley Madowski at the HIV/AIDS Bureau for their continuing support for not only this initiative, but for NQC in general. So thank you for that. And Michael, I would turn it over back to you for our maybe one more remark about evaluations, and then I'll turn it back to you.
Thanks so much, Clemens, and thanks so much, Emily. It's a treat and a pleasure every day to wake up and to come to the office and do this work alongside all of you. Just a quick plug for our video. If you've not seen it, the End Disparities video is a great 3-minute presentation that goes into some of the thinking behind this initiative and why we started it with our federal partners. You can access it directly from the enddisparities.exchange.org website, or it is on our YouTube channel. As Clemens mentioned, we definitely do want and need your feedback in order to make sure that we provide the most efficacious programming for you as part of this initiative. The system will be emailing you within 5 minutes with a quick 10 to 15 question survey. It's really fast. It says it's a test. It is not a test. I just wasn't able to change the marker within the WebEx system. But please do complete that evaluation exercise, as it really will inform the way that we put these programs together for you. Your opinion really matters. And then last but not least, thank you. Thank you, everyone, for joining us today and for your passion in creating the best program possible for people living with HIV in your service center. We wouldn't be anywhere without you, and you are the light in the darkness. So thank you for all you do, and thanks for joining us today, and we hope to see you next time. This is Michael Hager, the National Equality Center, saying thanks for joining us and have a great day.
Thank you.